Thank you very much. Thank you, Gaston, for the kind introduction. Good morning, everybody, and thank you for the invitation to talk about the clinical considerations about people aging with HIV. So, as you've heard, I work at Chelsea Westminster Hospital in London. So today I'm going to share my experience of what we are doing at the moment within the context of the aging person living with HIV pathway. Disclosures. Now, just a brief introduction, which I think you're all aware. Now, why are we talking about aging and HIV? What is going on? And the literature is quite rich in terms of data telling us that people living with HIV are aging, they're stable on antiretrovirals, and we know that antiretrovirals are now leading to the achievement and maintenance of an undetectable viral load, and therefore people living with HIV can have life expectancy very similar to people without HIV. What, however, seems to happen is that people living with HIV who are aging are affected by polymorbidity more often than people without. And we will have a look at what these are and what we think the reasons behind it can be. So this slide shows the results of a cohort study from the Netherlands, the Age HIV study, where you can see that with increasing age, the number of comorbidities, which are obviously not the opportunistic infections that you see in people with advanced diseases, AIDS. This is non-HIV associated comorbidities, is higher than in people aging without HIV. This paper is quite recent, and it's a paper from the UK really looking at a cohort that investigates premature, accentuated, and accelerated aging. And this is also very important because something we see a lot, or we're starting to see more and more, is people aging with HIV showing a high number of comorbidities or showing pre-frailty and frailty at an earlier age. And there were studies from the States showing that comorbidities in people living with HIV can develop earlier in life, and this is a confirmation of that from the UK. And it interestingly does support the model of premature aging in people living with HIV, because cardiovascular disease, hypertension are developed at a younger age in people living with HIV compared in people without. Importantly, the burden of chronic kidney disease is also increased over time. And in their study, they didn't see an earlier development of diabetes. However, other studies in the literature see higher rates of diabetes in people living with HIV and at an earlier age. So every study shows us always something slightly different, but the trend is clearly moving to the knowledge that people living with HIV are aging prematurely. And interestingly, I did mention very quickly, antiretroviral treatment led to the achievement of a life expectancy, which is very similar for people with HIV to people without. However, if we look at the presence of comorbidities, the life expectancy is impacted, is affected. And this is why it's important we're knowledgeable about the aging process in people with HIV. And you can see that you have lower life expectancy if you have HIV risk factors, and then remarkably lower with comorbidities, and then remarkably lower with drug and alcohol abuse. Now, why do we think people with HIV age prematurely? It's probably a multifactorial situation where Well, aging is not preventable yet. If you found some solutions for it, please let me know. I'm in. I'm going to join the clinical trial. But obviously aging happens, but also people with HIV are on antiretrovirals for a long period of time, so drug toxicity, especially, I would like to add, the older drugs that we've been using for 20 years, and sometimes we don't even actually prescribe anymore. Persistent immune inflammation, chronic inflammation, which is probably a consequence of HIV infection itself and the microbial translocation that occurs at the beginning when HIV infections happens. And very importantly, also lifestyle factors like smoking and drug intake. Now, all of these may lead to premature aging that may affect certain organs because the comorbidities that I mentioned mainly involve brain, bone, kidney, heart, liver, and also some cancers. And also from a clinical management point of view, let's not forget that if people are living with HIV and with polymorbidity, they're highly likely to be on polypharmacy. So I heard you talking about drug-drug interactions when I walked in earlier, and that's a very important topic for the management of HIV, and I'll talk about it a bit more later. This is one of my favorite studies, actually. It's the GEPO study by Giovanni Guaraldi and team in Italy. The reason why it's one of my favorite studies is because it really pinpoints one of the reasons why people living with HIV may have higher rates of pre-frailty, frailty, and maybe earlier in life. So, well, first of all, it's a real older people studies because there's always a bit of a confusion around what do we mean for older. So within the HIV field, we always use a 50 as an age, saying above 50 you are at higher risk of. This study looks at people older than 75 years old. But what they really highlight is that the only factor that we're able to see being predisposing to frailty, predisposing to polymorbidity and polypharmacy was the length of HIV infection, which I think it could mean that people using older drugs are more likely to be affected today, and also in the older days, we weren't starting people earlier. Now, I'm not talking about same day, 1 week or 2 weeks, like Laura was talking about. I'm talking about not leaving people off drugs for prolonged period of time. The newer antiretrovirals are much better tolerated and can be started much earlier. So we actually have been having a clinic dedicated to people aging with HIV for 10 years. We started it in January 2009. And it's run by consultants, junior doctors, pharmacists, very important because of polypharmacy and interactions, nurses, very important. And I'm going to tell you what we do in the clinic and try to justify it with the literature. So we are very, very careful about co-medications and drug interactions, including herbal remedies, recreational drugs, and making sure that the drugs people are on are working or they are not becoming toxic. These are two examples of people attending the clinic. You can see a 67-year-old and a 59-year-old. You can see the number of drugs these people are on. Sometimes they come to us and they are also on rosuvastatin and atorvastatin, and that's a mistake. There's on so many pills because of the polymorbidity and the management by different doctors. So we really try to implement drug reconciliation and deprescribing. We really try to optimize antiretroviral combinations and maybe remove boosters, remove the darunavir-ritonavir if there is not resistance there, and they have been on that for a long period of time for other reasons. So optimization of antiretroviral therapy is really at the front of our thinking in general, but very much for people on polypharmacy. And polypharmacy means being on more than 5 drugs, and it's definitely a clinical concern because it is associated to higher rates of drug toxicity and drug-drug interactions with negative outcomes. So very important, you'll see it throughout the literature, be aware of polypharmacy and drug interactions. The number of medications is remarkably increasing with age in people with HIV. And we published a few years ago this data from the POPI Cohort study. This is a cohort study that is run in the UK and Ireland and is comparing clinical outcomes in people who are living with HIV above the age of 50, with HIV below the age of 50 and without HIV above the age of 50. This paper was focused on drug-drug interactions with potential negative outcomes among non-antiretrovirals. So we know that more drugs you're on, more likely you are to have an interaction between the antiretroviral and the non-antiretroviral. But in people who are aging with HIV, the drug-drug interactions between non-antiretrovirals, those that you don't find on the Liverpool website, but that you have to actually go through the summary of product characteristics or to the BNF, to other sites beyond HIV, are much more likely to occur in these people that we see in the aging clinic. And also, there have been presentations and publications, this is one of ours, about the anticholinergic risk. So we are talking about people who are aging earlier with frailty, bone disease, high anticholinergic risk, at higher risk of falls. And you can see what, fractures and complications, bone complications, and not only, are more likely to happen. So this really to make sure that we expand our knowledge to the management of this area of medicine. And I did mention the importance of the prescribing. Other things we do in the clinic, we do measure testosterone, total and free testosterone, especially when people report fatigue or have high cardiovascular risk or are known to have cardiovascular disease. That's in men. We also have a menopause clinic for women living with HIV, so we refer women with menopausal symptoms to the colleagues next door that runs the clinic, and we're also trying to see whether we can support the trans people living with HIV who are aging and kind of understand a little bit more about the range of comorbidities they present with and how to manage them, but especially how to prevent them. It would be great. With a bit of discussion, some people disagree about it. We do a PSA. The reason why we do a PSA is not because prostate cancer is more frequent in people living with HIV, is because they don't go to see their primary physicians where PSA screening is conducted. So sometimes we offer it in the clinic. We offer anal smears and we ensure mammography is done because, again, some women just come to see the HIV doctors and don't go to primary care and sometimes are cut out from screening programs. And this is data from the States showing that certain cancers are diagnosed earlier in people who are living with HIV compared to people who are not. And that's why we probably need to be switched on about it. Now, in terms of cardiovascular risk and cardiovascular disease, I'm sure you're all aware it has been shown to be more frequent in people with HIV compared to the general population. So we do measure cardiovascular risk with the traditional equations like the Framingham. In the UK, we use Q-risk quite a lot. Very importantly, we work on reducing traditional cardiovascular disease risk factors, as you would do for everybody. You might hear on the news that in England, the NHS is trying to cut funding for healthcare. So we are really all focusing on social prescribing, improving health, lifestyle, diet, exercise to reduce. It's not working, just in case you're wondering, but we are trying very hard. But I think for people living with HIV is even more important because, again, of the chronic inflammation and an increased cardiovascular disease rates. Obviously, smoking cessation is very important. So we do have a metabolic clinic that is linked with a physiotherapist and a dietitian so that people can be followed up when they start this process of trying to live a healthy lifestyle. We also are quite lucky because the radiologists are happy to perform coronary artery calcification scores, and if they are raised, we can refer the patients to a cardiology HIV clinic. So we have a cardiologist that expressed an interest and is working with us. So when we do this CT scan, and when the CAX is high, we send them to the cardiologist. And this is all around prevention of cardiovascular episodes. We actually published that there is a discrepancy between the traditional cardiovascular risk measurement equations and the results of the coronary artery calcification score. Some people have a low cardiovascular risk but have a very high CAX, so they still need a statin, and you wouldn't start the statin just based on the equation. So that kind of reassured us that all of the CACs that we that we request are useful. And then I mentioned the cardiology clinic. So in the context of bone health, we do request a bone mineral density scan, measure the Frax score, and measure the vitamin D. And this is because, again, of data in the literature that says that people living with HIV are increased risk of low BMD and also fractures. I think the data on fractures is a bit discordant. I don't think we see a lot of fracture in older people with HIV, but this data set saw them and saw that the risk of fracture is higher both for men and women. And the role of some antiretrovirals has been demonstrated on this. So this is the Frax tool that was introduced by the University of Sheffield, that you can measure the risk, the 10-year risk for fracture. You can calculate it as an equation in your patients. We follow the Yaks guidelines where we request a DEXA scan in everybody who is living with HIV and is above the age of 50. Because we also saw that the agreement between the Frax calculations and the BMD in people with HIV is not as high as the agreement that was demonstrated in people without, and probably because the bone disease is slightly different and the risk factors are slightly different. And also, as said, we see bone mineral density, we see osteoporosis at earlier ages. Finally, we check HIV-associated neurocognitive disorders. Very important, the social situation. This was already true before COVID, where people aging with HIV reported isolation, and that obviously had a major impact on their mood. They reported depression. They needed referral to psychology, and that also had an impact on their neurocognitive function. We asked them if they're concerned about their memory, concentration, and cognition, and whether anybody around them has expressed concern about that. If we are concerned and they express concern and they have never been referred to a psychologist or a psychiatrist, we administer questionnaires and try to measure how depressed they are, and also the level of anxiety, so that we can refer to psychology. If they refer memory problem, we administer an everyday memory questionnaires. These are all questionnaires that are validated. And if it is compromised, we can refer to psychology for neuropsychometric testing. And finally, what we are not very good at, but we're getting better, is to actually assess frailty and pre-frailty. And we are working with geriatricians. We are setting up a clinic. I mean, we've been running it for a while. Obviously, COVID didn't help any of this, you can imagine, because people stopped coming to the clinic. Everything happened virtually. But we are trying to introduce tools to assess frailty and pre-frailty with geriatricians to make sure that we prevent potential complications and we try to improve the quality of life of people aging with HIV. So we had this special clinic for 10 years, but what we are doing now, we don't have the over 50 clinic anymore. Everybody who is seen over 50 needs to undergo the extra test. We're really focusing on prevention so that people living with HIV can have a good life like everybody else. We just try to catch before these comorbidities are more likely to develop. As I said, what we have is co-specialty clinics, so cardiology HIV, geriatric HIV, renal HIV, where everybody can refer to. So rather than an over 50 clinic, we have an over 50 pathway, and we're kind of focusing more on the co-specialty clinics, because the over 50 clinic showed that it was quite remarkable in the context of management and prevention of comorbidities. So obviously it's important to deliver, the care equitably and make sure that everybody has access to the extra tests. Thank you very much for your attention.